welcome back Blood Talk fans. Today we are back for another episode in transfusion medicine or blood bank. We will start with foundations of blood bank, the ABO blood groups. In this video, I will give you an ABO blood group overviews, including genetics and Punnett square. I will include timestamp in the description box down below, so you can refer to that as well if there's any topic that you are particularly interested in. There are a lot to cover today. Without further ado, let us all click that like button, share, subscribe, and don't forget to click the notification bell. ABO blood group is the single most important blood group in transfusions and organ transplant. The ABO antibody are naturally occurring, which means our body make anti-A and anti-B or both naturally without having to be exposed to transfusions or pregnancy before. Because of these reasons, transfused patients with incompatible ABO blood types may cause immediate loss of donor red blood cells, which can be referred to as transfusion reactions. Transfusion reactions can lead to renal failure and death. There are different types of transfusion reactions such as intravascular hemolysis, extravascular hemolysis, hemolytic disease of fetus and newborn, and there's many more. If you want to know more about transfusion reaction, please let me know in the comment sections. Now let's get back to ABO blood group systems. Let's talk about genetics. Genetics and inheritance of ABO blood groups. We inherit one ABO genes from each parent. It is located on chromosome 9. Chromosome 9 form mother and father make up the offspring blood type. Each of the chromosomes carry A, B, or O, while O is considered as amorphous because O alleles encode for non-functional enzymes. O group phenotype is an autosomal recessive trait, which means that the offspring has to inherit it from both parents to express the traits. The ABO genes are codominant and follow the Mendelian genetics. We can predict the baby genotype and phenotype using the Punnett square. If we know the parent's blood type, we can try to see what combinations are the genotype and blood type that the baby could have. If both parents have group A blood, for an individual to express A blood type, the individual can either have AA or AO genotype. We can predict the baby genotype and phenotype using Punnett square. You can see that the baby will have phenotype A, but there are two possibilities for the genotype, which are either AA or AO. I will give you another example. One parent's blood type is AB and another parent's is A with the genotype of AO. Now your offspring can have one of the three blood types, A, AB, or B. This also can be used backward, which means if you know the baby blood type, we can try to find out the parent genotype. The ABO genes are not coded for productions of ABO antigen directly. They code for enzyme glycosyltransferase. This enzyme added sugar to the precursor, which then expressed as A or B antigens on the surface of red blood cells. Therefore, ABO antigens are not protein antigen. They are small carbohydrate epitopes on glycoproteins or glycolipids. The ABO expressions is also regulated and influenced by another gene, the H gene. The H gene located on chromosome 19. The H gene is coded for H antigen, which is a precursor structure for A and B antigen. Without H antigen, no A or B antigen can express regardless of ABO genotype. This gives rise to Bombay phenotype. Bombay is a very rare condition, but it is very interesting phenomenon. I will talk about Bombay blood type in another video. Here is a table showing glycosyltransferase and the sugar for each antigen. Notice that there are no enzymes for O antigen because the O antigen comes from the lack of expressions of both A and B genes. Take a moment to absorb this If you do not fully understand this table right now, it is okay. I just want to show you the genes, the enzyme, and the correlate antigen for each gene. We will talk about it more in just a moment. How does the H, A, and B gene interact with each other to form A and B antigen? Each gene coded for a production of enzyme alpha-2-L-fructosyl-transferase that transfers sugar L-fructose to an oligosaccharide chain on the galactose terminal. Once that happens, the sugar becomes H antigen. The H antigen is a precursor or base for the A and B antigen. Next, the A genes. In people with A gene, these people are able to make enzymes called alpha-3 N-acetylgalactoamine transferase, which transfer N-acetyl-D-galactosamine at alpha-1 to 3 linkage to the subterminal galactose of the H antigen. This attachment changed the H antigen to an A, and now the individual will refer to as having an A blood group. In the case of people with group B blood type, the people have B genes. The people are able to make an enzyme called alpha-3-D-galactose transferase, which transfer D-galactose at alpha-1 to 3 linkage to the subterminal galactose of the H antigen. Once that happens, the H antigen gets converted to B antigen. For individuals with blood type AB, both A and B antigens are produced. How about people with group O blood type? Refer back to the table I showed you earlier. You will see that there are no enzymes responsible for transferring O sugar to the H antigen and convert H antigen to O antigen like group A and B. That is because the O gene is an amorphous which does not code for any enzyme. So for people with O genes, the antigen on the red blood cell surface is H antigen. Side note: in most people, the ABO antigens can be found on the surface of red blood cells and in secretions. However, the antigen structure is different. The structure on the red blood cells is a type 2 chain, but the structure in the secretion is type 1 chain. The difference between type 1 and type 2 chain is where the galactose attached to the N-acetylglucosamine. Type 1 chain is when the galactose attached at beta 1 to 3 linkage, whereas the type 2 chain is when the galactose attached at beta 1 to 4 linkage. Just remember, odd number go with odd number. Type 1, beta 1 to 3 linkage, secretion. Type 2 chain, 2 even number, 4 even number, type 2 chain, beta 1 to 4 linkage on the surface of red blood cells. Let's put all the bits and pieces of information together. Here's the type 1 chain with H sugar and with the A or B sugar added onto it. And here is type 2 chain with H sugar and with the A or B sugar added onto it. Here is a summary table for ABO phenotype and genotype. Since ABO is naturally occurring antibody, our bodies produce antibody for antigen that we do not have. That means a person with O blood type will naturally produce anti-A, anti-B, and anti-A, B. A person with A blood type will naturally produce anti-B. A person with B blood type will naturally produce anti-A. A person with AB blood type does not have anti-A, anti-B, and anti-A, B because the individual has all the antigens expressed on the red blood cell surface. If you look at the possible genotype, the ABO genes are codominant genes, so a person would have to get O genes from both parents to express O type. The A and B genes are the dominant genes, which can express when inherited as homozygous or heterozygous gene. That is it for today's episode on ABO blood group systems. I know it's a lot of information, but you can come back to it as many times as you like. Hello, Blood Talk fams! Today we are still on topic of transfusion medicines or blood bank. Last week we talked about genetic makeup, genotype, and phenotype of ABO blood groups. If you missed that, don't worry about it, you can check it out at the end of this video. Today, we will be focusing on ABO subgroups. I also include timestamps in the description box down below, so you can refer to it at any time. Without further ado, let us all click the like button, share, subscribe, and don't forget to click the notification bell. All testing should be performed as soon as possible following collections to minimize the chance of falsely positive or falsely negative reactions that will occur due to improper storage or contamination of the specimen. Any discrepancy that occur should be resolved before ABO blood group assigned. Side note, do not use sample that drop into the gel separator tube because the gel will interfere with the testing and could give you false results. However, if the patient needs blood emergently, do not refuse giving blood because you can always give Group O for RBC or Group AB for plasma and plasma products. I will talk more about blood product choices in emergency case at a later time. Nonetheless, it is wise to give patients his or her blood type and cross-match compatible whenever it is possible. Before talking about unexpected reactions for the subgroups, we should know what we are really looking for first. In most patients, these are the reactions that we will expect to see when performing ABO typing tests. This is a summary table of how the reaction should look like for each blood groups. The testing procedures and methodology will follow in the next video. Blood group O. This person do not have enzyme to add sugar to convert H antigen to O antigen. Since the ABO antibody are naturally occurring, which means a group O person will have anti-A and anti-B. Blood group A. The person will have A antigen on the surface of red blood cells. Our body does not program to generally produce antibody toward our own antigen, which means that a group A person will make anti-B antibody and not anti-A. An individual with group B blood type. This person will have B antigen on the red blood cells, and we can expect to find anti-A in this person's serum. A person with AB blood groups will have both A and B antigens on the red blood cell surface, which means that this group of people will not have anti-A or anti-B. Now that we understand and know what to expect for common blood groups reactions, we can then take a look at the unusual reactivity you will think of ABO subgroup or discrepancy when you perform ABO grouping testing and the forward and the reverse doesn't match. ABO subgroup represent phenotype showing weaker reactivity with commonly used reagent. Subgroups are more common in group A individual. The most common subgroups that are encountered are A1 and A2. There are other subgroups of A, but these two are the most common ones, so we will be focusing on A1 and A2. We can suspect A subgroup when the forward give A blood type and the reward give a strong reactions with B cells but a weak reactions or rough with A1 cells, which mean the individual may have one of the A subgroup with anti-A1 antibody. We already talked about how the reaction should look like for group A blood type. But how can you tell if the patient is A1 or A2? Is there a way to tell that? Yes, you can, and let me tell you how. Here is the reactions you expect to see if you test the patient's RBC with anti-sera A and anti-sera A1 lactin. For the patient with group A1, there will be agglutination for anti-A and anti-A1 lactin. But for the people with A2 subgroups, they will show the reaction with anti-A1 reactions but not anti-A1 lectin. In short, group A1 RBC react with both anti-A and anti-A1. Group A2 RBC react with only anti-A1 and not anti-A1 lectin. Anti-A1. Anti-A1 is naturally occurring IgM cold reacting antibody, and if the individual is only produce IgM, it is unlikely to cause a transfusion reactions. However, in some individuals also produce IgG, which cause a transfusion reactions in 37 degrees Celsius. Side note: inheritance of an A1 gene produce higher concentrations of enzymes than A2 genes. These higher concentrations of enzymes allow the conversions of almost all H antigen into A1 antigens on the red blood cells. I want to point out that we can classify A subgroup into A1 and A2, but the sugar that convert H antigen into A antigen is still N-acetyl-D-galactosamine. Here is a table showing reactivity of A subgroup. Subgroup of B are rare and much less frequent than A subgroup. There are a few techniques that can be used to identify weak B subgroups. First, strength and type of agglutinations with anti-A, anti-A, and anti-H. Second, absorptions illusion study with anti-B. Third, the presence of B substrate in saliva. Fourth, molecular testing. Here is a table showing reactivity of B subgroup. Hello, Blood Talk fans! Today we are still on transfusion medicine, or blood bank. Last week we talked about genetic makeup, genotype, and phenotype of ABO blood groups already. Today focus is on discrepancy in the forward typing. I will also include timestamp in the description box down below, so you can refer to it anytime. Without further ado, let us all click the like button, share, subscribe, and don't forget to click the notification bell. A discrepancy exists when the results of a red blood cell test and the serum test do not agree with each other. This can cause from either unexpected positive or unexpected negative. One thing to not overlook when approaching ABO discrepancy is technical error. Technical error include things like labeling error, forget to add reagents or wrong reagents added to the test tube, cell suspension is either too thick or too light, expired reagents, contaminated reagents, or equipment failure such as uncalibrated centrifuge. Sometimes we can be too excited to solve the mystery of discrepancy and forget to double-check every step of the way. This can lead to more headache than it needs to be. Now, if you're already double-checking everything and can positively rule out technical error, we can take a look at what else can cause the disagreement between forward and reward typing. There are different ways to categorize the discrepancy, but I like to group them into two groups: red blood cells problems and the serums or plasma problem. The red blood cells problem is when weaker reacting due to missing antigens or having an unexpected reacting due to extra antigens or having mixed field reactions. The serum problem is also when weaker reactions or missing reactions, but due to missing antibodies, or having an unexpected reactions due to extra antibodies. If you keep these two things straight, then you will have an easier time understanding this concept: antigens on red blood cells, antibodies in serums or plasma. Let's start with red blood cells problem. Red blood cells problem is when the red blood cells give an unexpected result. This can happen for many reasons. First, weak ABO expressions. Some diseases like leukemia can also lead to a weaker expression of red blood cells antigen. This is why patient's history is very important. Second, mixed field agglutinations. As the name suggests, they are the mixture of two populations of cells. This seen in patients who has been recently transfused. They are agglutinations and there are some free floating cells. This becomes more obvious when examined under microscope. Most of the time, we can see this when a non-group O person has been transfused with group O RBC. This can be solved by asking patient transfusion history. We generally ask if the patient has been transfused within the past 3 months. Why 3 months? It's because red blood cells has lifespan of 3 months. We can also see this in bone marrow and stem cell transplant patient. Third, thick cell suspensions. Thick cell suspension can neutralize anti-A and anti-B typing reagents. We can solve this by making a new cell suspension and making sure that the cell suspension is about 3%. A quick and easy reference is by looking at the A1 cell bottle. You can mix the A1 cells bottle to a homogeneous mixture. That mixture is about 3% cell suspension. So compare the two solutions and make sure that it is about the same concentrations before using your cell suspension for ABO typing. Fourth, acquire B. Oh, this is a fun topic. An acquire B phenotype is when an individual is actually group A, more specifically group A1, and currently typed as B blood type. This happens in patients with gastrointestinal bacterial infections. The acquired B phenotype shows strong agglutination with anti-A and weak agglutination with monoclonal anti-B. Solve this problem by retyping using acidified human anti-B. Acidified human anti-B does not react with acquired B antigens. Also test the patient's serum with their own red blood cells because the patient's own anti-B will not react with the acquired B antigens on their own red blood cells. If you want to know more about acquired B, please feel free to let me know in the comment down below. Fifth, LULO. LULO is a condition that makes the red blood cells become very sticky because the extra protein in the serums. The red blood cells stick to each other in a stack often referred to as a stack of coins. To solve this problem, wash the red blood cells, then repeat the test. 6. Water jelly. Water jelly comes from connective tissues and can be found in cord blood. So when we perform ABO typing using cord blood, we should wash the cell first to avoid interference from water jelly. Water jelly causes false positive. Besides washing the red blood cells before performing the test, we can also request for a heel stick. Hello, Blood Talk fans! Last week we talked about ABO discrepancy. It was getting really long and overwhelmed, so I break it down into discrepancy from the forward type, which was previous week video. Today we will continue on the subject ABO discrepancy, but we will be focusing on the reverse type, which come from the antibody in serum or plasma. I will also include timestamp in the description box down below as usual, so you can refer to it at any time. Without further ado, let us all click the like button, share, subscribe, and don't forget to click the notification bell. Once again, a discrepancy exists when the results of red blood cell test and the serum test do not agree. This can cause from either unexpected positive or unexpected negative. Serums or reverse type is not as expected. If the reverse reaction is weak or absent, can be due to following reasons. First, newborn. Even though the ABO antibody are naturally occurring antibody, but the productions of A antibody and B antibody is not detectable until about the age of 3 to 6 months. Second, elderly. As the patient age, the antibody productions can decrease, and it can decrease to the level that it cannot be detected in the patient's serum or plasma. Third, illness. Some illness can cause decreased productions of antibody, such as leukemia, or lymphoma. Fourth, ABO subgroup. We have an entire video dedicated to ABO subgroups, so you can go watch that at the end of this video. I have some suggestions in how you can solve the problems when you have an ABO discrepancy. However, keep in mind that you have to follow your workplace procedures and policy when approaching ABO discrepancy. First, repeat the test, making sure that the reaction you got is reproducible and there's no technical error in the process. Believe you and me, we can solve many problems by simply repeat the test. Things happen, maybe you get distracted, or maybe the tubes weren't labeled correctly, maybe someone switched the reagent. Who knows what happened? Just repeat the test. Second, get to know your patient. Get patient history, because that can help you determine the root cause of weak reactions or missing reactions in the reverse typing. Third, if the patients produce less antibody, we can give some time for the antigen and antibody to react to each other before centrifuge. By incubating for 15 to 30 minutes at room temperature, if that doesn't solve the problems, we can try to incubate it at 4 degrees Celsius for 15 to 30 minutes. Fourth, co-antibodies, which include anti-I, anti-H, anti-M, anti-N, anti-P, and Lewis. We can do a few things to try to solve these problems. We can perform grouping using pre-warm technique or break the IgM bonds using 2-ME. LULO. Yes, this is the same reasons as for red blood cell discrepancy. A good indication that we are dealing with LULO is when we have a stronger immediate spin and a weaker reactions at 37 degrees, with no agglutinations at room phase. LULO caused by increased amount of protein in the serums. We can solve this problem by performing saline replacement. This will remove the excess proteins and allow the reagent cells to react with patient serum without protein interference. 6. Bombay phenotype. This is rare, but very interesting. I may make a video about this at a later time. This patient produced anti-A, anti-B, anti-A, and anti-H. We can solve this problem by testing the patient's serums with anti-H lactin, no agglutinations because the patient with Bombay phenotype does not have an H antigen, which is a precursor structure for A and B antigen. Without H antigen, no A or B antigen can express regardless of ABO genotype. Hello Blood Talk fans! Today we are still on the topic of transfusion medicine or blood bank. However, it's not all boring and all theory today. I will walk you through how we actually perform ABO testing manually using the tube methods in the laboratory. ABO and Rh blood groups is the most basic and most frequently ordered test in blood bank. I talk about ABO blood groups in depth in another video already. I will leave a link to them in the description box down below. Please check it out at the end of this video. Today, we will be focusing on testing methods and procedures for ABO typing. I also include timestamp in the description box down below, so you can refer to it at any time. Without further ado, let us all click the like button, share, subscribe, and don't forget to click the notification bell. Let's start from up top. When specimen is received in laboratory, usually it is the laboratory assistant who will receive and accession the specimen to make sure that the specimen meets specimen collection standard. Remember, the patient identification is the most important step. Wrong patient means wrong sample, which means wrong test results. ABO blood group incompatible transfusions can cost the patient life within minutes. If you want to refresh on specimen rejection criteria or specimen collection standard, you can find a link to it in the description box down below. Step 1. Follow laboratory protocols on receiving specimen. Usually include verify that the sample is properly labeled, name, and medical record number are legible. On the label, it should include the phlebotomist's initial, date, and time of collection. However, some hospitals implement computer systems that the collector identifier, date, and time of collections is in the system. So sometimes it won't be on the label. So double check with your policies and follow that. Each place is a little bit different, but you cannot go wrong when follow your laboratory policy. Step 2. Centrifuge the sample for about 10 minutes at 3,400 RPM. Again, follow your laboratory procedures. This step is to separate the serums and the red blood cells. The reasons we have to separate the serums and the red blood cells because the ABO typing has two parts, the forward and the reverse type. The forward using RBCs and the reverse using the serums. Forward typing is defined as using known sort of commensals antisera to detect antigens on an individual red blood cells. Reverse grouping is defined as detecting ABO antibodies in the patient's serums by using known red blood cells reagent, A1 cells and A2 cells. Step 3. Checking all the reagent that you are using the correct lot number and that they are not expired. The reagents are to be QC daily and with each new lot number and new shipment. Expired or defect reagents can give you false test results. For instance, expired reagents lose their strength and can give you false negative when the reactivity is actually positive. These lead to wrong blood type. Step 4. Label 6 tube with patient names and Eman number. Step 5. Take those 6 tubes that label in step 4 and label each tube with the reagent name. The first tube label anti-A, second tube label anti-B, third tube is anti-A, B. This is actually optional, but if you wish to do so, then in step 4, you will label 7 tube. Tube 4, label D4. Tube 5, label D5. Tube 6, label A1 cell. Tube 7, label B cell. Side note, the tubes that are labeled D4 and D5 are used for Rh blood group antigen testing. This is what gives persons positive or negative notations after the ABO blood type. Rh testing is routinely done together with the ABO blood type as it is the second most important blood group in transfusions and transplant. Step 6. Place 1 drop of reagents into a clear, properly labeled tube from step 9 and 10. Step 7. Make a cell suspensions of about 2 to 3% of patient red blood cells and put 1 drop of 2 to 3% patient red blood cell suspensions into tube labeled anti-A, anti-B, and anti-A, B if you choose to do so. It's optional in a routine testing, but play an important role in neonate testing. D4 and D5. Add 2 drops of serums into tube labeled A1 cells and B cells. Step 9. Mix the contents of the test tube gently and centrifuge the test tube for about 15 to 30 seconds. Step 10. Gently resuspend the RBC button and examine for agglutinations, grading the presence of agglutinations accordingly from 0 to 4 plus agglutinations. A grading of 0 means no agglutinations present. Here's how to read the agglutinations. 4 plus. A 4 plus means a single agglutinins or large aggregate with clear background. 3 plus means a number of large agglutinins with slightly reddish background. 2 plus means medium size aggregate with reddish background. 1 plus means many small aggregates, turbid reddish background. Sometimes we also use R to indicate tiny aggregate, and the background is really grainy and has like a turbid reddish color. Step 11. Write down the reactions. Once you write down the reaction results that you got, then you can compare the test results to the table here, and you get your blood type. Troubleshooting for ABO typing. First, if you see weak reactions in reverse typing, you can try to incubate your test tube for about 15 minutes to enhance weak serum reactions. After 15 minutes, repeat step 9 and 10. Second, cord blood sample needs to be washed before performs ABO grouping test. The water jelly could interfere with agglutinations. Insufficient wash. The water jelly contamination gives false negative results. Water jelly is a gelatinous substance within the umbilical cord. Third, if the suspension is too thick, it will give you a false negative result. If this quick troubleshooting does not work out for you, you can check out how to troubleshoot ABO discrepancy. I have a video about that already. Facts that is good to know about ABO groupings. Serum and plasma are not the same, but both can be used for blood groupings. Serum has no clotting factor because the blood was aligned to clot before separations from red blood cells and serum. Plasma has clotting factor. This means serum plus clotting factor is equal to plasma. The ABO typing can also be done on a microscope slide. The process is mostly the same, but instead of doing it in a tube, we will do it on a microscope slide. And instead of using a centrifuge, we're gently tilting the microscope slide in a circular motions for about 2 minutes. If we observe agglutinations within 2 minutes, it means a positive result. If there's no agglutination, which means a smooth suspension at the end of 2 minutes, it means a negative result. And remember, do not place the slide on a heated surface. Hello, welcome back, Blood Talk fans. Today's video, we will work on some ABO discrepancy problems. We have been talking about ABO discrepancy for a while. Today, we will go over step by step how to solve ABO discrepancy problem. This is just a guide to help you approach when you see an ABO discrepancy. I have some examples for both the discrepancy in the forward typing and the reverse typing. I will also include timestamp in the description box down below as usual. Without further ado, let's get into it. In the previous weeks, we have been talking about ABO discrepancy. A discrepancy exists when the results of the forward and the reverse doesn't agree with one another. The patient blood type is not conclusive. So before we can assign a blood type to a patient, we have to solve this problem. Also, before we can give a type-specific blood to a patient, we have to solve ABO discrepancy problem first, because we want to provide safe and compatible units for the patient. Here are some steps to work on ABO discrepancies problem. First, repeat the forward and revert type. Do not forget to wash the cells before repeating the forward typing. If the discrepancy goes away, you can report the results. Second, if the discrepancy persists, record the reactions, whatever you got, and continue to the next step. Third, get patient history, like patient age, recent transplant, recent transfusions, or any health conditions that the patient have. Fourth, identify if the problem is coming from the patient forward type or reverse type by looking at the reactions. Ask yourself if you are looking at a weaker than expected reactions or a missing reaction. Then follow the guidelines as we talked in the previous video. Let's take a look at some examples of ABO discrepancy problems. Take a moment to look at this reactivity. You can pause the video if you need more time. What blood type do you think the patient have? And how would you approach this problem? So when you look at these reactions, there's no reactions in either forward or reverse. When you're looking at the forward reactions, you get O blood type. When you're looking at the reverse typing, you get an AB blood type. The red blood cells antigen is usually reacting really strongly. So my first thought is missing reactions in the reverse typing. This means that the patient is potentially type O, but missing anti-A and anti-B in the patient's serums or plasma. I will assume that I did everything correctly and I get the same reactivity when I repeat. First, check the age of the patient and the patient diagnosis. Second, incubate the test at room temperature for 30 minutes or at 4 degrees Celsius for 30 minutes, or you can do both. Third, read the reaction again. If the reverse come up, you can tell that the patient is group O with weak expressions in the reverse typing. What are the possible causes of these weak reactions of group O? First, the really young and elderly patient usually have weak expressions in the reverse typing. This is because a newborn does not make antibody until 4 months of age. And that's why we do not routinely do a reverse typing on a newborn. Also, as the person grows older, the immune system does not function as well as before. So we can see a weaker expressions of the patient antibody. And that's why some of the elderly patients, the reverse does not come up. Also, this type of reactions can also see in a patient who is taking immunosuppressed drug. Second problems. Again, take a look at these reactions. What do you think the patient blood type is? And what would you do to solve the ABO discrepancy? You can pause the video if you need more time. First thing, write down the type for the forward and the reverse. The forward give you type A, and the reverse give you type AB with a weak reactions in A1 cells. It is more likely to have an unexpected reactions in the reverse typing because the reverse type A1 cell is weaker than all the other reagents. Here are some steps to solve the problem. First, type patient with anti-A1 lactin. Second, use the patient's serums or plasma and type with A1 and A2 cells. Once you do that, if the results come up as no agglutination with anti-A1 lactin and agglutination with A1 cells, your patient blood type is A2 with anti-A1 antibody. How about if you see this type of reaction? What do you think the patient blood type is? Take a moment to take a look. You can pause this video if you need more time. You have example where there was no reactions, and now you have example where they all react. The forward gives type AB, and the reverse gives type O. What would you do? We have discussed this in the previous video. There are a few possibilities that can cause this type of reactions. The common ones are LULO and co-antibody. So you will take a look under microscope. If you see morphology of a stacking of red blood cells, mean you have a LULO. We can solve this problem by performing saline replacement. Once you perform saline replacement, you should not see agglutinations, and that's confirmed your suspicions of LULO. Possible cause of LULO is patient condition, such as multiple myeloma or arthritis. For co-antibody, you can test these suspicions by incubate the reverse at 37 degrees Celsius or perform the test using a pre-warm technique. If the reaction disappears, then you are more likely to have a co-antibody, which can be confirmed by perform co-panel. Okay, one more example. What would you do if you see this type of reaction? The forward gives you type AB with a weak expressions in anti-sera B, and the reverse gives you type A. Looking at these reactions, I would suspect that the problem is in the forward type. There is an unexpected reaction in anti-serum B. Here are the steps to solve the problem. Check patient history for lower gastrointestinal problems or septicemia. If the patient has history of lower gastrointestinal problems or septicemia, then it is possible that the patient has an acquired B. To solve these problems, repeat the forward typing in acidic environment, and type B in acidic environment only react with true group B person. Thank you for staying with me until the end. What do you want to know next? Do you want to know more about blood bank, chemistry, microbiology? If you have any burning questions, please feel free to leave me a comment down below. Lastly, if you have not done so, please like, share, subscribe, and click the notification bell. I will see you in the next episode of Blood Talks. And as always, remember, your blood tells you the story of your health. Thanks for watching. Bye!